in Jewish bioethics at Emory University. He also serves as a professor in the Department of Medicine, Pediatrics, Psychiatry, Neuroscience, Biological Behavior, Sociology, and he is the director of the Center for Ethics, also at Emory University. Before his service at Emory, he was on the faculty of University of Pennsylvania for 2 decades. He served for 15 years as a senior bioethicist for NASA. He still consults with them. Widely published in fields of sociology and medicine and bioethics, as well as in Jewish circles as well. His work focuses on social, religious, ethical, and ideological impacts of medicine and technology on the human condition. He is a renowned teacher, and his opinion is sought out by many really around our country, around our world. I'm so thrilled and honored that you agreed to take this chance to speak with me and with our congregation and anyone else who might be joining us. And so Dr. Wolpe, thank you so much for being with us today.
Well, it's a great pleasure. Thanks for inviting me.
Thank you. So I want to just jump right in. There are so many questions on top that are really top of mind for so many right now. But before we kind of dive into the details, I wonder if you could just give a little bit of insight for us about what it means to evaluate a situation through a lens of ethics specifically,
Sure.
as distinguished from a moral evaluation or any other sort of analytical lens, just for the purposes of common understanding.
Right. So I think people misunderstand what ethics is, and I think it's the fault of people who try to explain what ethics is. We're taught from very young that what ethics is about is right versus wrong. And I have been trying for 40 years to teach people that sometimes ethics is about right versus wrong, but that's usually the very fundamentals. It's usually what we teach our children. For adults, what ethics always is, or at least 99% of the time, is not a right thing versus a wrong thing, but 2 values in conflict, and how you decide which value to privilege over the other one. And almost every ethical dilemma, if you think through the ethical dilemmas you've had in your life, you will see that if it's right versus wrong, it's usually pretty easy to figure out the answer. Where ethical dilemmas become difficult is when you have 2 values, both of which you want to honor, but you can only honor one of them. I've taught medical students for 40 years. You have a physician treating a patient. The physician has an obligation to do what's in the patient's best interest, but the patient wants them to do something else that the physician doesn't think is in their best interest. What do you honor? Do you honor your obligation for beneficence, doing what's in the patient's best interest, or your obligation to honor their autonomy? 2 values, both good, both positive, you can't honor both of them. And you'll find that that's true throughout adult life, is that when we're really grappling with an ethical issue, it's not because one of them's right and one of them's wrong and we can't figure it out. It's because it's 2 values that we care about and we can't satisfy both of them. Morals is how each of us calculates those ethical dilemmas in a way that lets us resolve them.
Thank you. That's so helpful. So I imagine in some respects, morality may play into which value we ultimately choose to prioritize, but that process of the choosing in and of itself is distinguished from morality sometimes.
So sometimes, so first of all, you should know that in the business, as we say, in the ethics business, there are different definitions of ethics and morals. So there isn't one agreement of what ethics is versus morals. If you Google the 2, you will see, and I've had my students do it many, many, many times, that you can pull a number of different definitions out of what the difference is between the 2. And I don't think we should get caught up in it, because I don't actually ultimately think it's important what the difference is between ethics and morals. What's important is the question, how do we make ethical or moral decisions in our lives so that we live lives of integrity? I mean, that's really the question.
Perfect. That's a beautiful framing to kind of flow into the next overarching question. So you are, readily exploring the multiple ethical dilemmas that are presenting themselves through this COVID-19 pandemic reality in so many variable situations. I wonder if your sense in your analysis so far, or your work so far, is that is there a way, or is there an overarching ethical framework that can be applied throughout all of these variable situations? Or is, from an ethical evaluative standpoint, is it important to analyze each situation particularly through its own, you know, values, variables, what have you?
So the challenges that I've been dealing with and my colleagues have been dealing with are very different from each other. So we've done a lot of work on the healthcare system and how we make tough decisions of allocating resources. We've done work on how we prevent the poor and the disenfranchised and the disabled from being discriminated against. We've done work on how you balance community need versus individual need. We've done work on the ethical challenges of social isolation. And I think each of them are different, and they do require different ways of thinking. That being said, the basic underlying ethical principles are the same. And, you know, they have to do with respect for persons and individual freedom and group responsibility. And as I said earlier, it's how you balance them in any particular situation, as I'm sure we'll see as we get into this, that I think really is the key. And just to say, there are different systems that have been proposed in human history for doing that. And of course, we as Jews have a system as well where we think about it. And as we move in, I'll try to give a couple of examples, one in particular that I've been dealing with, where the Jewish answer to something is actually different than the answer that most people have given in the United States.
Fascinating. Yeah, that was going to be another one of my questions, is what do we do then when those two operative systems, if they apply in both ways for us, how do we navigate that? So we'll come forward. So given that, I want us to kind of explore, dig into a few different overarching areas. And the first one, which I think is so top of mind, we see it in the news and we see it just in our own questioning, is the idea in the medical realm of the rationing of resources. You know, how should the medical world, should we be thinking, understanding, again, through an ethical framing, about how hospitals should decide who gets treatment, who gets a ventilator, the workers who get PPE equipment or not? Right.
So when the COVID pandemic first started to become so prominent in our country, what I and my colleagues did was write these policies for our healthcare institutions. I'm a bioethicist. I'm the president this year of the National Association of Bioethics Program Directors. And so all of us run bioethics programs. All of us, most of us, are affiliated with hospitals, and we had to write these policies. What do we do if we get to the point where there aren't enough ventilators? How do we triage people? How do we send them to what kinds of services when there are conflicts? We also then gathered these together and wrote a couple of professional articles that have just come out last week and this week, looking at that exact question. So what is normally done or usually done when you're triaging someone to a ventilator is you look at their medical status. So there are measures that are used to try to determine how well a person is doing physically. For example, there's one called a SOFA score, and that stands for Sequential Organ Failure Assessment. And they look at your liver function, your kidney function, your respiration, your blood coagulation, your neurological function, and a couple of others, and they give you a score. So one of the things that was proposed very early was someone with a higher, if we have two people, both of whom need a ventilator, and we only have one available ventilator, let's look at the SOFA score. And the person who's doing better, who can benefit from the ventilator, has a better chance of benefiting from it, so let's give it to them. So the first two principles that people tried to use were benefit and need, not the same thing. You and I, if we were both going after the same ventilator, you might need it more, but I might benefit from it more, or vice versa. So those were the first sort of proposals. And many systems use those as their first line of decision. The challenge there are a number of challenges there, but one, for example, is how much of a difference do we need before we privilege one person over another? If my SOFA score is just slightly worse than yours, that doesn't necessarily mean you're going to do better. So there was that kind of issue, and there are others that I'll give you in a second. But I want to say, then there were what we think of as second order questions. Age. So age was a big one. Some policies use age, some policies forbid using age. Age can be done in two ways. We can say younger people get it before older people. But there too, you have that sliding, scale. So if someone's 42, they get it over someone who's 43. Is that meaningful? So then people talked about life stages. So I'm 63. If I were 63 and then someone else was 25 and we both needed the ventilator, that person, I've gone through young adulthood, middle age, right? And now I'm in my senior years. That person has just started young adulthood. They haven't had as many life stages as me. They should get the ventilator. So again, some policies say use that. Some policies say you can't use that. Then there's pediatric versus adult. Interesting thing with COVID, unlike the flu, seems like younger children do better than older people. So at the beginning, they were saying, well, what are we going to do if pediatric hospitals run out of ventilators? Now the question is, can we borrow ventilators from pediatric hospitals? Then there was healthcare workers. Should we privilege healthcare workers? So the question came up, if two people were both equal in other measures, and one was a healthcare worker, should we give it to them because of either a reciprocity, that is they are working there so in a dangerous situation, so we should help them, or need, that is, or outcome, that is if we pull a doctor through COVID, then they will go out and treat 20 other people. And the third is through fear that if healthcare workers aren't privileged, they'll say, why am I risking my life if I don't have this benefit? So again, some places do privilege healthcare workers, some places don't. And there are others too. But so those are some of the ethical principles that people have tried to use. One last thing before I get off of this, and that is, it would seem if we came up with a policy and we put it in place, whether you agreed with the policy or not, at least we've made the ethical decision. The problem is there are all kinds of hidden problems in those policies. And I'll just give you a quick example. Take a SOFA score. Seems pretty obvious. If I have a higher SOFA score, why shouldn't I get the ventilator? Well, that immediately set off the disability community. The disability rights group said, look, we have chronic conditions, we have lifetime struggles. We're going to start further behind than other people. Why should I be denied a ventilator because I have a lifelong struggle that makes my body have a lower SOFA score than someone else? So that's an example of the issue. Access is an issue. Not only access in terms of people in rural areas being further away from hospitals, so less likely to get there or get there in worse condition, but also, people who live in inner city areas who don't have cars. So they have to get on, they're having COVID symptoms and now they have to get on a crowded bus and get to the hospital. So hidden inside of those policies are other kinds of ethical issues that we have to think about and not just assume that the policy makes sense, so it's going to work the way it's written.
And do you feel, or have you found that, there's some commonality in the organizations that privilege one approach over another? Like, do religious hospitals lean one way versus teaching hospitals lean a different way? Or is it really just the individual culture of a given institution? And
well, that's great that you asked that question. We didn't find much differences between institutions, but there was a study that found a lot of differences between people, in the sense that religious, non-religious people were much more likely to look at need, things like benefit and need, as the key, most important and only criteria. while religious people were much more likely to also look at other issues. And I'll give you a perfect example where Judaism, for example, comes down on a different side than policies that secular institutions use in an interesting way. So a lot of hospitals, what they'll do is, here I am, I'm on a ventilator. I'm not doing that well. The doctors believe the ventilator might help, I might pull through this, but what they thought were pretty good odds before are now much diminished. Another person comes in who could use that ventilator. We might, in a secular hospital, take the ventilator off the person not doing well and give it to the other person. Judaism would not allow that.
You cannot, right?
Right.
Yeah.
You can't take life-saving equipment away from me to give to someone else, even if they might benefit more from it, because benefit is not the only value that we use to determine, there's something that they call, I have a contingent relationship with that. And when you give it to me, you've given it to me to take me all the way through to an outcome. So Judaism won't allow that ventilator to be taken off to be given to someone else. So there's an example where some of the secular policies are going to differ from the way Judaism would suggest that they be done.
Yeah, as soon as I hadn't thought of that at all, just as a rabbi and a Jewish person in this whole experience of COVID-19, until the minute you said that, I knew where you were going.
I saw your head start to
yeah, and oh my goodness, you couldn't. Oof. So one more question along these lines, as we imagine or as we pray that a vaccine will be discovered and found and produced, and obviously that's conjecture, but if that is to come, would you say you would apply a similar paradigm of these ethical values one to the other in terms of how that gets administered, in that same benefit over need or life stages or healthcare gets it first versus others, same idea at play?
Sure. Yeah, I think there's a lot of similarities. So a lot of policies were written over the last few decades for a flu pandemic. And the CDC has a policy for flu pandemic, and so do a lot of institutions. Now, in a flu pandemic, you're like at COVID with the elderly, but unlike in COVID with pediatric patients, they're at great risk. But what's interesting about the flu is young, healthy people, like in their 20s, are in some ways at greater risk than people in their 60s. Why? Because what the flu does is the thing about the flu that kills you is an overreaction of your immune system. And the stronger your immune system is, the more at risk you are. So in the giant 1918 flu pandemic, where 50 to 100 million people were killed worldwide, it was soldiers in World War I who were dying of the flu in mass. In fact, more soldiers died of the flu than died of the war. So, interesting question. Who do we give a flu vaccine to if we had one and there was a flu epidemic like the COVID one that was coming? Do we give it to young, healthy people? Will the country allow that? Will they stand for that? Let's give it to 20-year-olds before we give it to babies and the elderly. So there's both what makes sense to do from a purely medical perspective, but there's also another sensibility that we bring to it where we want to protect people that we think of as vulnerable or in vulnerable classes. So if we got a COVID vaccine soon, obviously we should give it to the elderly before the young and healthy, because here it's very clear that the elderly are at great risk. We should probably offer it to healthcare workers because they're putting themselves at risk. But how far out do we go? So we give it to healthcare workers. Do we give it to our grocery workers who are, stocking the shelves and putting themselves at some risk? Do we give it to people who have to take public transportation and therefore every morning are putting themselves at risk? How we assess risks becomes itself an ethical question.
Ethical issue. Yeah. I hadn't thought of that either. These are issues that obviously, you know, you're so enmeshed in, but I wonder if as each stage unfolds and we kind of come to certain conclusions or guidelines for how to approach situation A, when situation B then is birthed out of it,
Yeah.
you know, there will be entirely new ethical dilemmas born out of it, and assessing risk, as you say, being a profound one. So that, I think, segues into exactly the direction that I want us to go, which is, you know, is there, from your sense, is there a particular ethical demand of healthcare workers which is different from other workers, essential or not, in terms of working, coming to their job, while they are knowingly putting themselves at risk to some extent or to a large extent? And then is that any different than, say, a healthcare worker who lives with a vulnerable family member, an elderly family member, or somebody with compromised health?
So it is, as you know, a very complex question. I think it is clear that if you are going to enter the healthcare profession where you're going to deliver direct care, that you should do that knowing and that you may be putting yourself at risk sometimes. Hospitals are places where people are sick, and therefore hospitals are places where you can get sick because of them. And healthcare workers should know that, and healthcare workers take on a certain responsibility and obligation. So yes, I think there is a moral imperative on healthcare workers to continue working. It doesn't mean that if a healthcare worker decided to quit because of this or something that they shouldn't be allowed to. Obviously they should. But there is a certain morally persuasive argument to be made that they should continue to work even in the face of a pandemic. That being said, it bestows on us, meaning all of society, an equally compelling moral obligation to make sure that they are protected as possible, and we did not. So the failure here is our failure, not their failure. That is, any healthcare worker that refused to go in because they didn't feel like they could get the protective equipment they need, the moral onus is on us, not on them. We had the obligation to make sure that they were as protected as possible given their job. And you know, the failure to have personal protective equipment across the board, across this nation, in sufficient amounts to protect our healthcare workers is a national shame. And you know, I am pretty sure that it's not going to happen again. I think hopefully one of the positive things that may come out of this is much better preparedness. Public health officials and epidemiologists have been warning us for decades that this was going to happen. This isn't new. This isn't something that took us by surprise in general. The specific did. And we should have been better prepared.
Yeah, you know, as you were saying that, I immediately start to think about Teshuva and what does that even begin to look like as a nation?
Absolutely.
In terms of not just being better prepared next time, but for owning and accounting for this failure. And I think it's easy to sort of, I appreciate how you speak of it as we and not a they. What is the collective societal obligation? We are all part of it. And what does each individual then, who is not a healthcare worker, what responsibility did we have, could we have stepped into in a more significant way, and how will we repent or make teshuva around it?
Right. And that's a very Jewish approach, of course, because we make teshuva collectively in Judaism, not individually.
Correct.
Right? I mean, we have a tendency as human beings to overreact right after a crisis, then underreact as it extinguishes, right? So, you know, for the next 5 years, we'll be ready for any epidemic, I'm sure. And then 20 years from now, 30 years from now, who knows? I mean, we were ready for the next epidemic after the Spanish flu, and now 100 years later, it's all, you know, a lot of that's gone. Part of the question is, to what degree are we willing to give resources every year for a preventative, defensive cost that we might not actually have to use year after year after year? It's a very difficult thing to sell. And it's especially difficult for politicians. That's why our infrastructure is falling apart. That's why a lot of these things are happening. But we have to be more mature about it than that as a society. And we have to demand, we do it for defense. And, you know, this is, aside from defense, this is the great enemy that can destroy us, are microbes.
Yeah, I mean, it is defense. I understand, you know, in the technical sense that it isn't, but I mean, it's just an expanded reality. Yeah, thank you. As you said that, it reminded me a few other questions that had come up over the past week had to do with that, the allocation of our own resources moving forward, or where we are now in terms of, I know in the Jewish community or in the larger community, people are wondering like, well, I have a limited pool of dollars with which I can allocate tzedakah or charity. And how should I be considering these allocations? You know, who has the greatest urgent demand? What is, perhaps we should be thinking about this preventative, a longer term lens, and what would triage in that sense look like? What should be prioritized first? I wonder if you have a framework for that.
So my attitude towards tzedakah is always the need far exceeds any person's ability to fulfill it. And all of us choose those things where our heart is. I mean, if all of us gave our tzedakah to pandemic preventiveness, our, you know, poverty would still run rampant and our ecology would fall apart and all that, right? And so there's something actually satisfying and beautiful about the fact that I really care about animals and you really care about the poor and she really cares about hunger, and that way we give our money in a way that spreads the need around to so many different places.
And heart directed is a nice way to think about that. I like that phrasing. So let's then move forward into the more universally experienced reality of this pandemic, which is kind of this balance of life versus livelihood. You know, all of us, certainly those of us who are watching this interview in my congregation, we've been sheltering in place since mid-March, and many of us began a sort of modified version of that at the beginning of March. And I think this is a pretty shared experience at this point throughout the country. And we feel the impact of that psychologically, economically, socially, really pervasively. At the same time, I think there is this notion of sacrificing for the greater good and the protection of life, or preventing hospitals from overflowing, and the different articulations of the need for sheltering in place.
Sure.
From an ethical lens, what is the balance? How might we navigate balancing reopening society, in particular in these non-essential, whatever that means, outlets, versus protecting and limiting the spread of infection, protecting life?
Sure. So in the medical ethics world and the bioethics world, there actually is a difference between bioethics, which looks at the obligations of medicine to individual patients, and public health ethics, which looks at how we as groups get healthy. And they are in tension. And they're in tension in a lot of different ways, and always have been. So when we think about allocating ventilators, we move from a individual bioethical standard to a public health standard. That is, in a bioethical standard, when there's no shortage, the obligation of the health system and the physician and everyone else is to do what's in the absolute best interest of the patient sitting in front of you. In an epidemic, the obligation is always that too, but when you get into allocation, it is to do what's in the best interest of the society or the community, which means that I want to maximize this resource for the community, and so certain individuals are not going to get that resource. And it's the same thing, for example, So there's a lot of work around surveillance. So one of the ways in which you want to try to maximize going back to work and going back to social life is through what's called contact tracing, where you try to figure out who I had contact with, who you had contact with, and who is tested, and testing is part of this. You have to have good testing. Who has tested or who has been exposed to COVID, so that I know that, oh, I've been exposed to COVID and here are people I've come in contact with, so they need to get tested. And there are all of these ways to do that. So in China, they're putting cameras up in front of the houses of everybody who's had COVID or tested with COVID. In fact, they're putting cameras sometimes in their houses, and they're actually giving people certificates with QR codes on them that they're okay because they've had COVID and survived. So that's how they're doing it there. South Korea, for example, the first patient in the United States to be identified as having COVID was identified on January 20th. The first patient in South Korea was identified on January 20th. So we started exactly the same day. By the end of March, South Korea had done 400,000 COVID tests. By the end of March, the United States had done 40,000. And we have 330 million people and they have 80 million people. So they did this massive testing program immediately. They never had to shut down their society. They never had to close their businesses because they knew exactly where COVID was breaking out and they could contain locally. And they've had a lower incidence of death, and they're back at work. So this was a failure of US preparedness and leadership around this epidemic. If we had done it the right way, these decisions may not have to be made. And I think that's a really important point before we go to the decision itself. And that is, we've put ourselves in this situation that we have to make this tough ethical decision. It was not inevitable. Other countries avoided it by handling this the correct way. That being said, there are some suggestions on how we might do this. For example, Apple and Google have gotten together, created an app. In Israel, for example, they created a very similar app, and that app is being downloaded all over Israel. And what it does is you download it and you voluntarily put your COVID status in it. And then when you and I talk in person, our phones Bluetooth with each other. And then when I leave, you get a message on your phone saying you've been exposed to COVID, because my phone knows that I've been exposed to COVID and I've talked to you. So that's a new kind of contact tracing. In the old days, they would just interview you and say, so who have you spoken to this week? So there are some technological fixes that might help us do this a little bit better. But there's also a seichel problem, and I'll give you an example. So I live here in Georgia. I'm in Atlanta. And our governor decided to, in a phased way, open up businesses. Nothing wrong with that in theory. Everybody's going to have to do it. A lot of governors are doing it. But what are the first businesses he opened up? Haircuts, massage services, tattoo parlors, bowling alleys. I mean, he opened up high contact businesses. Exactly. He didn't open up, Target and Walmart, where you can actually socially distance yourself if you want to, or you can set them up that way, the way grocery stores try to do. So we need to roll this out in a way that makes sense, that takes advantage of the best understanding of how to protect ourselves, of public health officials and epidemiologists and those who work in these areas. And different states are going to figure this out differently. There are going to be different criteria. Even here in Georgia, when he opened up the restaurants, some restaurants opened, some restaurant owners said, no, I'm not opening because I don't think it's ready. So we're going to have 1,000 little experiments to try to do this in the best possible way.
So I wonder in that example of tracing, right? Like, sort of the idea that we can opt in to share information about ourselves. And in these cases where there is this dialogue between the good of public health for the good of society versus our individual freedoms, rights, however we want to understand that. From an ethical standpoint, let's take that example of letting Google or Apple know our COVID status. Is it ethically right for us, or should we be compelled, because it is ethically right for us to give personal information that many of us wouldn't normally be willing to do for the sake of this good? Or I guess the flip being, these are my personal freedoms and there should be no ethical weight one way or another, because it is by the nature of it being freedom, it is totally my choice and nothing should impact that.
So let me give you, there are two aspects, well, there are a lot more, but there are two aspects to this I want to address. The first is that same obligation I was talking about that we have to healthcare workers to protect them. If we are going to tell people that we're creating a system whereby they have to or should, could be, moral compunction versus a legal compunction, put these on their phones, then we have to be absolutely sure we've protected people, that these data cannot be used for anything else, that there are legal protections, that, there aren't accidents like we see all over the place, that they're not hackable. We have to protect people, and we're not always so good at doing that either. But there's another interesting piece of this, and here we'll bring Judaism back in. So we in the United States, and in the Western world and my post-Enlightenment world, talk about rights, and we think of life in terms of rights and what our rights are, and people can't take away our rights. And there is no concept of rights in Judaism.
In Judaism, right?
In fact, there's not even really a word for rights in biblical Hebrew. So what Judaism talks about is our obligation one to another. And that's what the entire Torah is about, is how do we fulfill our obligations to God and to each other. And so we in the Jews of the West have adopted the rights language, and we tend to, bang on the table and talk about our rights. That's not a Jewish perspective. The Jewish perspective is, how can I best participate in protecting other people's health and the health of the ones I love? And that is, to me, a compelling argument for why we should engage in these kinds of activities, and we should try to use the technology available to us to protect each other. Yes, it has to be done in a way, as I say, that itself has integrity and protects us from unintended consequences. But once we're assured that that's what it is, yes, I think we have a moral as well as a religious obligation to use technologies like that to try to protect others.
I so appreciate the articulation of that differential between, Western society, American society versus the Jewish worldview, the Jewish paradigm. When I have these conversations, I often will say the same thing that you did, except I'll say, if, our right is that we have freedom, but freedom to serve, freedom to serve God, freedom to uphold God's creation. That's the God-given right, as it were. It is a service outwardly to each other, to the larger framing. So I really appreciate that, and I think it does help distill. If for those interested in navigating this through a Jewish frame, I think it does distill and provide a lot of clarity into how should we be acting. We as individuals, we are not governments. We are not, I don't think that the leader of the United States is watching this this recording, so given for the folks who are here, I think it is an opportunity to really consider what we can choose to guide us and which framework we will take up. Thank you for distinguishing that. Just two very specific questions that congregants at North Shore Congregation Israel wanted to ask that were unique, and I want to just throw them out there for you. The first was, is it ethical to purchase non-essential items online? With the quagmire here being that on the one hand, you're providing jobs to supply chain workers, and this is upholding livelihood. On the other hand, it is keeping them at risk, knowingly at risk, and how might we navigate that?
So I don't have any problem with that because, here again, it's a balance of value. They're working, but we have no reason to believe that that workplace is not carefully designed to keep them as safe as possible. And one suggests that one guesses that it probably is, because there's so much attention on these things right now. And most states have mandated gloves and masks and things like that. My issue with it is actually a slightly different one, which is that what we have done in our culture is we've concentrated so much of our purchasing into these giant centralized businesses that we have destroyed local economies. And so these economies aren't operating right now because of COVID, but they will again. And as soon as they are, I'm going to feel an incredible moral obligation to go out and support them, my local businesses, my local small businesses. They estimate that a quarter to a half of all businesses may not be able to recover from this. So that's where I feel my moral obligation. I'll tell you something else, a little bit off topic, that I think is really a beautiful Jewish teaching about this that reflects that kind of sensibility. So it actually says in the Talmud that you are not allowed to go into a store to look at an item that you then go and buy cheaper at another store.
Right.
Now, how many of us go into stores and look for something and then go and buy it cheaper on Amazon? That's a violation of Jewish sensibility, because you are exploiting the first business person in order to make money for the second business person. And so what I would like to see from an ethics perspective is for us, to stop doing that in general, but also to go out and try to do what we can to shore up our local business environments once we can, and not to use all these online merchants, especially the biggest ones. Though right now, when they're the ones delivering needed goods, I think we use them.
And I'm sort of, again, just I'm reflecting back to the idea of Teshuva, like what will a collective Teshuva be like for this whole situation? And I wonder if one of the steps of that reparation, one of them could be that we commit to, local commerce and invest in that space, all the more so than we would have previously, as an act, forget it's an ethical act, yes, of course, but also as an act of Teshuva. And how might that catalyze saving and healing in our own local economies? I think of like Jewish tort law, which I imagine is similar to American tort law, but the obligation is always greatest in proximity to you, and the farther out you go, you are obligated, of course, to damages globally, but your immediate obligations are those who live in your house, those who live in your neighborhood, those who live in your village, those who live in your town, in these concentric circles moving outward. And I think that framing is going to be really important. Okay, and so last question, again, in this balance of rights versus public health, and it may be the same answer. I'm just curious, once this pandemic is over and when we start to reopen society, whenever that is, we imagine that, private institutions may want to partake in steps to limit the chances of COVID occurrences in their institution. So for example, like taking people's temperatures or things like that. Right. How ethical is it for a private institution, say a synagogue, to take people's temperatures before they come in?
I think it's fine. This is again about obligation versus rights, isn't it? So yeah, I have a right not to have my temperature taken, perhaps, but I also have a right not to walk into the synagogue. And my right to not have my temperature taken ends when your exposure puts you in some risk. So no, I don't have any problem with those kinds of things. They, again, like everything else, they have to be measured, they have to be thought through, they need to be done with sensitivity and looking for and at these hidden biases that creep into these things that I was talking about at the beginning, and they're always there in one way or another. That being said, I think some people still think of this pandemic as something that at some point in 3 to 5 months will be over, and it won't. There's no switch, there's no moment, as Fauci said. I mean, this is going to be something that drags on for a year and a half, till we have a vaccine. Who knows, exactly when the point will be that we feel like it has been mostly finished. I want to point out, and I don't want to scare people, but I want to point out that the 1918 pandemic that killed millions and millions of people had a flare up like this,
right.
Then it calmed down, and then the one that really killed the vast majority of people happened in the second wave. And there are epidemiologists predicting a second wave in the fall. I'm not saying that it's going to be like that. We don't know. This is a new, novel kind of virus. But I think people have to be prepared for the possibility that this is going to drag on for a very long time. And we're going to have to figure out how to live like this in a way that keeps us all safe for a long time.
Yeah, I so appreciate that framing. And I think it isn't to scare us, it's to empower us and to help us to be vigilant and thoughtful about how we will live our lives, which we are still living. Many feel that our lives are on hold. They aren't. We're living them now. And right. We won't look back and say, oh, remember that 6 month to 24 month pause where we didn't live? We did. It was lived differently, but it doesn't mean we aren't beholden to our highest morals, responsible to each other, ourselves, our world, our God, however we understand that. So I think calls to accountability and responsibility and awareness when we have data, when we have history, which has warned us, are so important. And I so appreciate that. And really on behalf of everyone who will see this in real time or who will see it afterwards, I want to thank you for your offerings, your insights, your knowledge. I feel so much more empowered with a framework in a different way personally than I did before this conversation. And I know so many others will as well. I'm grateful to you and wish you and your family safety, good health, and blessing in as much as that can come your way. I hope that you get to see some tree that looks like that tree in your background. You live in a beautiful area, so you can at least take in the beautiful nature around you. Thank you so much, Dr. Wolpe.
Sure, my pleasure. Thanks so much for inviting me.